Hi, good day to everybody. I'm Dr. Luah, consultant anaesthetist from Penang Hospital and the National Chair for Advanced Life Support Subcommittee NCORT. It's my pleasure today to be able to share with you the topic on resuscitation in COVID-19 pandemic. As clinicians, one of our priority is to provide patients with care aligned with their values and preferences in the event they become critically ill. But on the other hand, current resuscitation guidelines highlight the importance of rescuers' safety, especially at this period of COVID-19 pandemic. The staff's safety is paramount. So, for the next hours, I hope to cover issues such as clinical concerns, ethical elements, types of personal protective equipment, and worldwide resuscitation guidelines, mainly from NCORT, International Liaison Committee on Resuscitation, and what we have written and prepared for the local practice by NCORT, National Committee on Resuscitation Training. COVID-19 is caused by virus severe acute respiratory syndrome coronavirus 2. World Health Organization has declared COVID-19 as a pandemic on the 11th March of 2020. To date, this disease has infected more than 4 million people in the world and caused more than 300,000 deaths. But why is it so? Because COVID-19, this virus is very transmissible. Mode of transmission could be done via the droplets or airborne in specific circumstances. People can get the infection directly from the patient with COVID-19 or indirectly by touching contagious surfaces. Airborne particles is even smaller and can remain in the air for certain hours. How fatal it is. This is a statement from the WHO chief. We know that COVID-19 spread very fast, and we know that it is deadly and is 10 times more deadly than the flu pandemic in 2009. So worldwide, the mortality rate is about 3 to 5%, and in Malaysia, the mortality is less than 2%. And how did people die? Majority of these COVID-19 patients had respiratory cause for the cardiac arrest. Some develop arrhythmias, which is about 20% of patients, and some develop acute cardiac injury. There's one paper recently published in hospital cardiac arrest study done at the tertiary hospital in Wuhan, China. This involved 136 victims and presented the initial cardiac arrest rhythm. 89.7% are actually asystole, 4.4% presented with pulses electrical activity, and another 5.9% presented with ventricular fibrillation or pulses VT. Only 4 out of these 136 victims actually survived more than 30 days, and sad to say that only one patient survived with a favorable neurological outcome. So you can see the outcome of the COVID-19 patient, if reached the stage of cardiac arrest, the outcome is actually not good. So, in the resuscitation science, is there a difference when we have to treat or do CPR on this collapsed patient? Actually, that's not really the difference, because we are still using the NCORT worldwide resuscitation CPR guidelines for the patient. So, what are our worries? That we have to really look into it, because the clinical concerns. CPR involves the aerosol generating procedures such as chest compression, positive pressure ventilation, and establishment of advanced airway. Secondly, resuscitation efforts require numerous providers to work in close proximity with the one each and another with the patient. And thirdly, high stress emergent event I don't think any one of us will have enough time to really take care of ourselves and put up the full PPE. However, talking about the issue about AGP, aerosol generation procedure, WHO has categorized CPR as the aerosol generating procedure. And also, data from China has highlighted the potential risk to the healthcare worker when undertaking AGP in COVID-19 patients. In contrast, there are some national guidelines describe chest compression and defibrillation as non-AGP. And I think you would have come across that NCORT, they put chest compression under non-AGP procedure. So driven by the concerns, again, among the clinical community as the optimal approach to cardiac arrest, NCORT has actually identified the urgent need of a review of current evidence to inform international resuscitation treatment recommendation in patients with known or suspected COVID-19. And that's the paper. In fact, because of the urgent need, NCORT actually took only 4 days to complete this systematic review. And this is systematic review on the COVID-19 in cardiac arrest and infection risk to rescue users. This is actually done mainly with the aim to identify the potential risk of the transmission to rescue users during the resuscitation. This research or this systematic review actually come out the 3 research questions. One is actually in individuals in any setting. Question 1 is delivery of all the key intervention, for example, chest compression, defibrillation, and CPR, whether associated with aerosol generation. Research question 2 is delivery of any of these key intervention associated with transmission of infection or not. And question number 3, the effect of different personal protective equipment strategies during the CPR. All these studies, in fact, they identified 38 papers, and at last only 11 papers are actually reasonable to actually answer all these 3 questions. There's no study describing patients with COVID-19, but includes all types of infection, for example, viral, bacterial infection, and fungal infection. And NCORT did a search on the MedLine, M-based Cochrane Central Register of Control Trial, WHO COVID-19 database, involve all years up to 24 March 2020. And this involved randomized control trial, non-randomized control trial, case control studies, case reports, and mannequin study. So what is actually the outcome? The results. To answer question number 1, there are 2 papers actually involved. And NCORT did not find any direct evidence that chest compression or defibrillation either did or did not generate aerosols. In fact, there are 2 papers showing healthcare providers actually contracted infection during the CPR. But because the CPR was a prolonged CPR, so it is likelihood that the healthcare provider would have been exposed to other key interventions, for example, like intubation. Question number 2, the answer also did not find any evidence that chest compression or defibrillation either are or are not associated with transmission of infection. Similarly, these observation studies, there are actually 8 papers, also revealed some healthcare providers contracted infection. But because this healthcare provider was involved in the resuscitation for more than 50 minutes, and probably it's likely that the healthcare provider that involved will have actually exposed in the rooms when the intubation was actually taking part. And question number 3, how about the effectiveness of different PPE during CPR? In fact, the effect was actually varies, and there's no evaluated outcome of infection transmission. However, after all this systematic review, NCORT has come up recommendations. Chest compression, aerosol generation, it is still possible because it can generate passive ventilation associated with small tidal volumes. And chest compression are just parallel or similar to some chest physiotherapy techniques which are associated with aerosol generation. In contrast, defibrillation has no evidence identified that it generates aerosol. So as a whole, NCORT recommendations suggested that chest compression and cardiopulmonary resuscitation has potential to generate aerosol, in which this is a big recommendation with very low certainty evidence. And in the current COVID-19 pandemic, healthcare professionals should use PPE for aerosol generating procedure during resuscitation. And the list of PPE will be mentioned later. So, as a clinician, to take care of patient care and to make sure healthcare provider protection is you have to find an important balance between these two. So, what we suggest, there is no emergency during pandemic. Safety comes first and do not do harm. Worldwide recommendation, there is this term being introduced, and this is called DNA CPR. What does it mean? Do not attempt cardiopulmonary resuscitation. Of course, this is not easy for our hospital cardiac arrest because you have no time, no info about the patient, but this is doable for all the in-hospital cardiac arrest. DNA CPR, do not attempt cardiopulmonary resuscitation, is actually the part of advanced care planning. It is a clinical judgment and it is not legally binding. But once the DNA CPR is considered, it will become a legal requirement that it must be a high-quality communication and discussions, of course, if time available, between the clinicians and patient or either patient's family based on a very clear clinical grounds that further CPR will not be successful for the patient and maximum care has been provided for the patient. If time not allowed, it can be done unilaterally, but it may be involve the primary care physician and the specialist who is taking care of the patient that agree that this patient is terminally ill and the vital signs are deteriorating despite the maximum ventilation and inotropic support. Or either it can be done with the family via the video conferencing, or if any advanced medical plan has been discussed and agreed upon the next of kin or family members. How about types of PPE, the personal protective equipment? This is the list provided at the MOH website when all of these are actually required for aerosol generating procedures. Number one, respiratory protection. N95 respirators or respirators that offer a higher level of protection. If we have a PAPR, which means the powered air purifying respirator, or N100, this will be recommended. Eye protection, people can use goggles or facial, gloves, isolation gowns, the fluid-resistant long-sleeve gown, head cover, and boots cover, and shoes cover. We would like to stress here, for all the cases of cardiac arrest, minimal requirement for PPE should include N95 mask, eye protection, and glove. You as a frontliner must prepare and know how to take care of yourself, because we will never know which patient will turn up to be positive COVID-19. How about out-of-hospital cardiac arrest, OHCA?
Of course, the adequate PPE is very unlikely. For example, a three-ply mask, face shield, but if you can, please prepare. It's recommended by Worldwide Health Corps or AHA or ERC, a face mask or cloth covering the mouth and nose of the rescuer or the victim may reduce the transmission of all these droplets transmission. Early use of AED, because as remember, the systematic review revealed that the defibrillation carry very minimal risk of actually or can be considered as a non-AGP aerosol generating procedure. For public CPR, we would recommend hands-only CPR, no mouth-to-mouth ventilation, and if first aider attending to the patient in the OHCA cases, avoid back mask ventilation. If you have no choice, must use two hands. If not, the supraglottic airway could be more superior to background mask. How about telecommunication? Dispatcher, CPR. For all this telecommunication, should screen all the calls for COVID-19 possibility. These include the symptoms, history of contact, and epidemiological risk. Dispatcher EMS team should be alerted to don the PPE if there is any suspicion for COVID-19 infection. How about in-hospital cardiac arrest? Over here, we have actually divided the measures prior to resuscitation, during resuscitation, and what we should do post-resuscitation. Measures prior to the resuscitation. Early identification of COVID-19 patient who is at risk of acute deterioration. Of course, if possible, to place them in the negative pressure room is the best, but it's not that easily available because negative pressure room is very limited in any hospital. Early monitoring and detection to avoid unprotected CPR. Early identification of DNA CPR, and all the resusc team members must be equipped and wear full AGP PPE. Healthcare workers must be trained to put on, don, and to remove doff the PPE safely. Some specific preparation, such as PPE, viral filter, the ET tube closed suction device, clear plastic sheets, and double-sealed plastic bag must be ready and kept at the resuscitation trolley at all times. And at the time of cardiac arrest, in case of collapse, do not do listen, feel for the breathing. Look for absence or sign of life and check pulse to confirm the cardiac arrest. This is a little bit different from the 2015 resuscitation guideline. Early defibrillate if shockable rhythm and defib machine, preferably if you have defib machine is self-adhesive pads. This will be the best because it limits the contact with actually the patient. Cover patient's head end with clear plastic sheet during CPR to minimize the risk of aerosol exposure. Of course, if you have a mechanical CPR device, consider this because this will also further reduce the exposure and restrict the number of healthcare workers in the resuscitation room. Allocate the gatekeeper. That's important because I have actually have a conversation with the senior consultants in another discipline in which he thinks that during resuscitation, we should train all the young doctors, especially the housemen, to do CPR. But I personally think that with this COVID-19 pandemic, we have no choice to limit the number of actually rescuers. And probably for our young doctors training, instructors like us, we have to think of for example, more chance to have clinical simulation on resuscitation to make sure they will be well prepared if the crisis happens. Then, if the patient collapse has been on oxygen, and we should leave it on and allow some form of passive oxygenation. Avoid the back mask ventilation if possible. Do consider early tracheal intubation by using a cuff ET tube with a viral filter to enable early establishment of the closed circuit ventilation. To remind everybody, airway intervention must be carried out by the most experienced operator to achieve the first success rate as possible. And there's another thing we have to remember is to pause chest compression for intubation. This is important because for the previous guideline, if you can, you do not pause the chest compression because chest compression interruption more than 5 seconds may affect the outcome of the patient. But in this COVID-19 pandemic, please pause the chest compression for intubation. We also should consider video laryngoscope if available, and all the ET tube must be cuffed appropriately, adequately, and secure properly before applying the IPPV. Clamp the ET tube prior to circuit disconnection or when connecting to the ventilator. More important thing, further, we have to use the inline closed ET tube suction device. Dispose all of the clean or all the equipment and any work surface used for the airway or resuscitation. Equipment used in the airway intervention should be placed in the double-sealed plastic bag before it's actually thrown. And do not leave the Yonker sucker under the patient's pillow. Put the contaminated end inside a disposable glove. Identify and treat any reversible causes before considering stopping CPR. When the patient has achieved return of spontaneous circulation, remove PPE safely. Dispose all the clinical waste as per infection control protocols. Hand hygiene is very, very important, and proper passover to other healthcare workers who will be receiving the patient. Communication with ICU regarding this disposition and timing of transfer. Preferably, use a transport ventilator in which a viral filter should be attached if available. Avoid the chest X-ray, ECG until ICU admission. Team to Dove, and then don new PPE prior to transfer patient as assumed to be heavily contaminated previously following the resuscitation, and ensure a clean path to ICU destination. This is very, very important. Next, how about in ICU? When ICU COVID-19 patient or SARI patient collapses. Very important thing is leave the patient on the mechanical ventilation via the viral filter to maintain a closed circuit. Do not and avoid manual back mask ventilation unless you think the tube has been dislodged. Or we have to adjust the ventilator setting to allow for asynchronous ventilation. For example, increase the FiO2 to 1.0, change the mode to the pressure control mode, limit the pressure as needed to generate adequate chest rise, which is about 6 ml per kilo, and adjust the respiratory setting to about 10 per minute. Very importantly, we have to ensure the endotracheal tube or tracheostomy tube and ventilator circuit connection are well secured, because CPR is a very vigorous process, and tube or circuit disconnection can happen if this is not well taken care of. If there's a return of spontaneous circulation is achieved, set ventilator setting as appropriate to patient's clinical condition and start the post-cardiac arrest care protocol as per existing guidelines. What happens if the patient is actually in prone position at the time of cardiac arrest? If the patient in prone position without the advanced airway, no choice. You have to place the patient in supine position and continue resuscitation. If the patient is intubated, We would suggest avoid turning the patient to supine, because by doing that, the chances for the tube disconnection or circuit disconnection is there, and this will increase risk of aerosol dissemination. We will consider placing the defibrillation pads in the anterior-posterior position or bi-axillary position and provide CPR with the patient remaining prone with the hand in the standard position over the T7 to 10 vertebral body. It's not easy.
This is the revised BLS algorithm by NCORT. Important highlights are: consider DNA CPR, don PPE if available, do not listen or feel for the breathing, check pulse if trained, early use of AED, hands-only CPR, allow passive oxygenation, and if back mask ventilation needed, advisable to use two-hand technique, but of course, preferably use the supraglottic airway device if available. Next, we also adapted the step-by-step flowchart for ALS algorithm from ERC. However, we have revised and adjusted pertaining to the local use. And this is just a summary that I have actually mentioned to you earlier. Lastly, this is the revised algorithm for ALS from NCORT. We have highlighted the important changes pertaining to COVID-19 pandemic in color boxes. And there are some reminders in what we need to do before, during, and after resuscitation. With that, I end my presentation, and thanks for your attention.